everyone, to our Research Connect series. My name is Linda Powell, a CDTRP PFD partner, patient family donor partner, and I will be facilitating today's webinar. I've been involved with CDTRP for a number of years as a PFD participant, engaged in themes 1 and 2, the Donation Organization Architecture chapter for the International Forums, and the CDTRP Media Committee, to name a few. I became involved as a result of my husband being listed for transplant from 2012 to 2014 and the difficult journey that entailed. Firstly, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I myself would like to acknowledge where I am speaking from, Millerville in southern Alberta, the traditional territories of the people of Treaty 7, which include the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda, and the territory home to the Métis Nation of Alberta, District 5 and 6, and acknowledge all nations, Indigenous and non, who live, work, and play on, and honor and celebrate this land. I encourage you to write your own land acknowledgement in the chat box. For our sponsors, we would like to acknowledge Astellas and CIHR, whose generous support enabled us, CDTRP, to host these sessions. Before we dive into the main content in our presentation, I'm going to pass it over to Erica for some general CDTRP dates.
Thank you, Linda. Today I have one announcement for you all. This year's annual scientific meeting will be held in a hybrid format with the in-person component in Calgary, Alberta on December 3rd and 4th. If you're interested, we are currently accepting poster and oral abstracts from all community members. The deadline is July 26th. I'm going to provide a link in the chat box. Thank you.
Thank you, Erica. Before I introduce our speaker, I have a few housekeeping notes. So today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have a question or comment, you can raise your hand with the raise hand button or type it in the comment section. Now I'm very pleased to introduce our presenter, Dr. Sonny Dhanani, who's very familiar to all of us. Dr. Dhanani is the Associate Director for CDTRP, investigator at CHEO Research Institute, and also Chief of the Pediatric Intensive Care Unit at the Children's Hospital of Eastern Ontario, Chair of the Canadian Blood Services National Deceased Donation Advisory Committee, and a steering committee member of Health Canada's Organ Donation and Transplantation Collaborative. His research area is in leading international research pertaining to practices and standards for determining death after cardiac arrest for the purposes of organ donation. We're all very excited to hear your presentation, and I'll hand it over to you now, Dr. Dhanani.
Thanks very much, Linda, and thanks, Erica, for the invite. It's a real pleasure, and I'm looking at the list of participants here. So it looks like a whole bunch of friends, and that's excellent because that makes me super comfortable. And actually, a lot of what I'm presenting, I think some of you have seen before, and so it's a nice chance to kind of review from a research perspective how we got here and what happened in my own journey that involved a lot of you. So I'll speak for a little bit, but hopefully we can have a nice discussion at the end about research today and in the future. Provocative title, When is Dead Really Dead? And it really is a chance for me to describe the immense collaborative effort of the DePPaRT study, which stands for the Death Physiology and Prediction after removal of therapy. I hope we'll talk a little bit about the controversies in deceased organ donation and death determination, and then review the study, which I haven't done with you for some time. So it'll be nice to do that for me, but then learn a few things along the way. Some disclosures is that I see Ronnie here. I have a position with Trillium Gift of Life as a donation physician, positions in leadership with Canadian Blood Services and Canadian Donation Transplant Research Program, and now also with Ontario Health. My story starts actually somewhere in 2005, 2006. I was not in the organ donation or frankly a researcher. I was very interested in transport medicine, and that was my shtick. Until we had a family in our pediatric ICU in Ottawa, 2 children that died in a car crash with their grandparents. And their parents were out of town for an anniversary and came back. And you can imagine just thinking of your own children, grandchildren, how that might have been, how tragic that was. These 2 children did not have hope for recovery, and we recommended withdrawal of life-sustaining therapies. They did not fulfill brain death criteria. And when family said, can they be donors? We said no. It was not 3 months later that in the adult world at the Civic Hospital in Ottawa, that a family asked the same question. And that in ICU in the adult world said, yes, we can do it. And it was the first DCD in Canada, donation after circulatory death. And I recognized that there was a missed opportunity, that we had families that wanted support in a grieving situation, and organ donation might give them that. And so I started that journey, and we created the first DCD policy in pediatrics. In fact, I think the Civic Ottawa Hospital did not have a policy, so we may have been the first policy in Canada, and that was 2006. This article, or this consensus group, came together, led by Sam Shemy, and had brought together some leading experts to say, let's do this here, but it had barely started. And so there was really an opportunity here. And just for people on the call who may not be clinicians, donation after circulatory death is not a new way of doing donation, but it's a new opportunity where previously we had the opportunity to donate organs once somebody is dead from a non-recoverable injury, receiving mechanical ventilation, and being brain dead. And there's some very strict criteria, but this was a pretty rare event in ICUs and really limited the number of people who actually could be donors. However, in the same situations of catastrophic injury, if we didn't fulfill brain death criteria, but there was an opportunity to withdraw life-sustaining therapies with improved surgical techniques and some ethical formulations, we were able to then approach families to, at least at the time, recover kidneys, then eventually livers, now lungs, and now, in fact, heart. So the opportunity to donate really expanded exponentially in the era. And I must say, Trillium Gift of Life was a key player in trying to increase those numbers. Following closely behind was Quebec, Nova Scotia, and the rest of Canada. So we've seen a lot of increase in donation in Canada, mainly because of the work done with this forum and the leaders that started this. However, it was a slow start. There were some controversial issues. When an individual was determined brain dead or determined death by neurologic criteria, it was clear that there was a fine line there, and then the process of organ donation could start after. But if they weren't fulfilling brain dead criteria, we then recognized that the conversation of organ donation and end-of-life decision-making had to happen before they were dead. And that created some ethical discomfort, and still does. Conflict of interest came up a lot. The process of withdrawal of life-sustaining therapies, could it be altered so that the opportunity to donate was enhanced? And the crux of this issue is that as one is dying from withdrawal of life-sustaining therapies, as you're removing the ventilator, in fact, your blood flow to those organs is limited. And so the time before you actually are determined dead and organs are recovered is quite tight, usually within 2 hours. And lastly, it was the determination of death. And I want to get into that a little bit. One of the fine the principles is that one must be dead, either from neurologic criteria or circular criteria, before organs are removed. Now, that was pretty well defined for neurologic criteria, but for circulatory criteria, when the heart stops, it hadn't been well discussed. And not only was there a lot in the media about patients wrongly certified dead, there were respectable news agencies that interviewed people in our field, and I think twisted the story and the narrative. And this is not a new thing. In fact, this has been occurring for many, many generations. In fact, that's why there are bells attached to some grave sites for fear that someone was declared dead. And in fact, that happened a lot during the cholera epidemic. And so these patents were created to ring the bell if you were buried prematurely. That's where Saved by the Bell comes from. And the medical literature actually brought this up a lot when DCD was starting. You know, should we fear the reaper? Were we out as clinicians just to get organs? Were they really dead? And was there an ethical or even legal ramification to starting DCD? Most clinicians really then stepped back and said, this is about trust. And that we wanted to increase the potential for donation for transplant recipients, but for our grieving families. But we did not want to break trust. That in fact, if we had an interpretation where we removed organs before someone was determined dead, then that would be catastrophic. I mentioned this fundamental principles. Now, what we thought, well, let's go back to the legal statutes and how does that support us? In fact, it was pretty vague. Even in the donation acts, it's clearly stated that physicians must be physically present. Well, I think that's pretty good. That in fact, for donation, 2 physicians should be present and do that determination, also pretty good. Where we might have failed a little bit is then it stated death should be determined by accepted medical practice. It's in quotations because that's what was in there. And what that opened up was what was accepted medical practice. I did surveys, or a team did surveys, and asked ICU physicians across the country. We got a pretty good response rate. And we said, how do you determine death? And in fact, there was a huge amount of variability. Some national recommendations that were in that DCD consensus paper put together suggestions of an absent pulse, an absent blood pressure, and no breathing. And then after 5 minutes of waiting, a second physician did the same. What we realized is that was all arbitrary. It's all very reasonable, but it was arbitrary. And there's no textbook that actually says it. In fact, when we asked people where they learned these things, it was mentorship. It was the physician before them who trained them. And so there was this understanding that, in fact, we were probably putting ourselves at risk if we didn't clarify this. Where did this 5-minute hands-off period come from to confirm death? It's a really important number because why not wait 10 minutes? If we're unsure, wait 10 minutes. But in fact, if we waited too long, those organs were further deteriorating. And in fact, some centers at the beginning had chosen 10, 20 minutes of absent pulse before recovering the organs, and those organs didn't do very well. But if we wait shorter than 5 minutes, and in fact, this happened in Denver in 2008, where they waited 67 seconds. What if that person wasn't dead? What if they were violating the dead donor rule and removing organs? I think trust was at play. There's this concept that kept coming up in this word called autoresuscitation. Autoresuscitation, as we define it now, is the spontaneous resumption of circulation once it stops. So i.e., the heart stops, the circulation stops, someone determines them dead, but then the heartbeat starts again, or electrical activity starts again. And this concept of autoresuscitation really stalled the implementation of DCD programs across the country. People were really afraid that they were going to remove organs before someone was confirmed dead. We did a systematic review, which is looking at the number of published articles internationally to say, were people actually documenting autoresuscitation? And in fact, what we found was that it probably wasn't real. There were lots of case reports. There were a lot of identified stories and reports of people being determined dead, but actually not coming back to life. And what they were reporting was stories like this: an emerge resuscitation, epinephrine given, a lot of intubation done, 20 minutes of CPR, and then everything stops. They go out and talk to the family, they come back, and then the patient is breathing again. In none of those situations were there actually monitors on the patient. So we didn't actually know where somebody actually had died right away, or whether they were coming back to life. We thought that was a real gap. And from there, we pitched an idea to CDTRP and CIHR to say, hey, I think we should go and study this. And so remember my journey starting from the bedside to then getting incorporated and energized with a family that was motivated, to then finding the right people to work with to try to answer a clinical question. That was my first lesson learned. Getting the right people together, Laura, Amanda, Melanie, Nathan, Sam, Shemi, and so many others, to work in a common goal is where research thrives. In fact, this wasn't a job. It wasn't hard to do. It was fun. It was fun. It was like-minded people with a vision to say, listen, we have a question and we're going to answer it. Did it seem like the biggest question to answer? But no, but it was relevant to us. And I think that was really super important. The next thing we gathered was family partners. Heather Talbot specifically is a mother from Toronto whose son died a few years before we met her. But in fact, when we brought her into the fold as a core team member, our experience really increased. And it wasn't about a token person participating in our research, though we were probably one of the first to incorporate a PFD into our research in a fulfilling way. I think we really learned a lot from Heather and her experience that again helped us motivate ourselves to go further. And I think it really helped us be successful in this endeavor. So many other collaborators, and we were very lucky in that we had the Critical Care Trials Group and the Canadian Donation Transplant Research Group that took a small idea from a small pediatric intensivists, and took it across the country. It wasn't easy. Imagine us going to family clinicians and saying, you know what, we actually don't have enough information on how someone dies. So we're going to go during this critical period where you've talked to a family and said you're going to withdraw life-sustaining therapy, and we're going to sneak in there and say, hey, do you want to do research? We're going to put monitors on and watch your family member and kind of intrude during this time. A lot of people on this list said no. It took time. It took engagement, and it took relationships. And in fact, that was what was so important. Now, a lot of European countries are a little farther advanced in donation. The Netherlands is where DCD started. The United Kingdom is probably 5 to 10 years ahead of us. And when they jumped on board, I think we really had momentum. Our research question really landed on what is the natural history of dying after withdrawal of life-sustaining therapies in an ICU? You see, I said an adult and pediatric patient. At the end, we only recovered or recruited 8 patients, which is a lot, more than any other study, but we never included them in the big study. But really, we wanted to see, does autoresuscitation really occur? And that meant keeping monitors on while they die. And then we wanted to build a model that predicted the time to death, because in fact, that prediction allows transplant surgeons to decide whether they're going to say yes to a donor or not. So it was a prospective observational study. We didn't actually intervene in any way. We included all ICU patients who were dying in the 20 centers, and we kept a saturation, which is the pleth, an ABP is an arterial blood pressure, and it wasn't a cuff, it was an invasive arterial line, so we can measure beat to beat and an electrocardiogram. We also, of course, because it was a rare study and it was sensitive, we allowed, of course, families to say no. We allowed health professionals to say no. And in fact, anyone could actually withdraw from the study right away. We were very fortunate with an extremely motivated team to then get published in the New England Journal of Medicine, which I think is pretty rare for an organ donation or transplant study. I think it's not the results that was so important that got us into this paper, but it was the relationships and the nature of the study. So let's describe that a little bit. We had families decide on withdrawal of life-sustaining therapies with their healthcare team. We had then families decide with their organ donation organization whether they were going to consent to DCD. And again, the relationships with the healthcare team and the relationships with the organ donation organizations across the country were so important here. Then our research coordinators.
That to 4 East, room 6. I repeat, that call.
I may have to go for this.
4 East, room 6.
Oh my God. Wait, hold on. I'm going to continue until I get called. I saw what Matt's. Is it still sharing?
It is not still sharing.
Okay, let me just get sharing. I can't believe what if I have to do that. Okay, am I sharing now?
Yep, if you could just put it on presenter mode. Thank you so much.
So we collected a lot of data, and the WLSM is the active withdrawal, usually an extubation, and then we continued keeping the monitors on, and we collected information up to an hour before and half an hour after they were determined dead. That's the first time anyone's ever done that. Usually we take all the monitors off and we declare them dead clinically. Even for organ donation, we only do it for 5 minutes. And then we ask the bedside, was there any reported autoresuscitation, resumption of circulation? Did people come back to life? And then we looked at the monitor data. 20 sites, families consented, 93% of families consented. And we thought this study we were told this study couldn't be done. We collected data from 631 patients. There were 67 actual donors, so we didn't just collect information from donors because our question wasn't about donors per se, but autoresuscitation. And I must admit, it took 13 years of my life. Clinical autoresuscitation was described actually 13 times. 4 a bedside clinician said, you know, they saw the heart rate and blood pressure come back. 2 said, oh, we noticed breathing, but nothing on the monitor. 6 said they saw just electrical activity, so no blood pressure. And 1 just stated, yeah, return of good waveform. So I don't know where that fit here. But were these real cases of unassisted resumption of circulation? Now, we had all this monitored data, what we call the beat browser. And so we went back and looked at all those cases, especially those 13. And this is what it looked like. The red line is a blood pressure, and that's really circulation. And that's probably what's more important. If you have electrical activity, which is in the green, is it as important as circulation? No, because that's activity of the heart and not circulation. And what's really important with circulation, is it perfusing the brain? That's probably how we should be looking at whether someone's alive or not. So we used artificial intelligence, and we used non-artificial intelligence with all these smart people. Some of you are on that. I'm going to take Matt Weiss's picture off for that comment, but the rest of these guys are excellent people. We had a panel that reviewed all these waveforms, every patient, to see whether there was a resumption of circulation. We reviewed it with our adjudication working group, and then went to our steering committee to identify what was real and what was not. A lot of diversity on this as well. We looked at those 13 identified cases from the bedside. In fact, 6 of them were just electrical activity. And so we felt that wasn't resumption of circulation. It had to be blood pressure. 2 of them were lost signals, but in fact, when we reviewed other markers, we didn't see a resumption of circulation. So we were left with 5 that had validated cessation or stopping of blood pressure for at least a minute before returning. This happened at 64 seconds, all the way up to 2 minutes and 56 seconds. And 2 of these actually happened in donor patients. What happened, if you were worried about it, is that the clock restarted, and they started that 5 minutes again, and then were able to be donors. So I'll run you through some of the things we actually saw. The top one is the blood pressure. The bottom one is electrical, and it stops. Stops for 2 minutes and 56 seconds. The little blips are artifact, and then it starts. That's a real start. And it lasted for 52 seconds. This was eye-opening for us, because remember the case reports we had seen in the systematic review was, it happens, but we've never documented it. So this was the first time we had documented return of circulation that wasn't involved with CPR. Oh, now I'm getting called by my daughter. Interesting. If we reviewed all 631 patients, not just the 13, I think what we saw was that, in fact, some of the waveforms weren't that great. And so we reduced the number of what we actually looked at to about 480. There was some unreliable, kind of 150 cases. But if we looked at those 480 patients just by the waveforms, not by the clinical now, we actually found 67 situations where there was one identified resumption of spontaneous activity and circulation. And we had some definitions of what resumption was, which is really a pulse pressure of 5 millimeters, which is very tiny. In fact, for the most part, often not even noticeable at the bedside. We were being very specific, trying to be true to our definitions. So in fact, this was about 14% of patients that we measured actually had spontaneous resumption of circulation. Now, I'm using that term now very carefully. I'm not calling it autoresuscitation for you anymore, because autoresuscitation implies returning to life, resuscitation to life. In fact, we saw resumption of circulation, but no one out of the 631 came back to life. this is some of the details of the data, is that most of these 67 resumptions occurred within 2 minutes. And most of them lasted less than 2 minutes. The longest time between stopping circulation and a return of circulation was 4 minutes and 20 seconds. And that's really important. Remember that 5-minute arbitrary window that we had been using for the last 10 years? In fact, this validated that 5 minutes. Not that it couldn't happen after 5 minutes, but we didn't find it. And so everyone felt very safe that we had been using a time period to determine death that was adequate. How long did these resumptions occur? Again, usually less than 2 minutes. In fact, a lot of them were, and it's maybe hard to interpret here, were only a beat. Most of them were only a beat. And so is that a relevant resumption of circulation? Probably not, but it was there nonetheless. And the longest one lasted 13 minutes and 14 seconds. That's a long resumption. None of these people came back to life. I'm going to skip this one. We just to note that we found a lot of things that have helped the donation process. We recognize that sometimes at the bedside, people weren't adjusting the monitors for very low flow states. And in fact, at this point, someone at the bedside declared that person dead. What we recognize is that actually this was a scaling of the monitor. And we can tell that because there's still carbon dioxide, which is the blue monitor, that when there's the ventilator breathing, there's still carbon dioxide being released, which means somebody is still alive. And if you notice in a second, that blood pressure comes back. But in fact, it probably never went away, that the monitor hadn't been scaled to identify the lower blood pressures. We also recognize that the electrical activity was different from blood pressure. And we really focused circulation on blood pressure because the green line is electrical activity, and that continues, even though there is absolutely no blood pressure, even when scaled, and it doesn't come back. This person is dead because electrical activity means the heart may be just quivering, but that does not mean that there's blood pressure. I've shown a lot of data and numbers and waveforms. I always like to pause to remember the individuals and the families that participated in this. This is numbers on a board, on a PowerPoint, but each of these families were going through a grieving process, and we were so respectful of that. And the families, I hope, took something. Not all of them were able to be donors, but what we heard over and over, that participating in research that might increase donation and transplant over the years was relevant to these families as they move forward. And so we were no longer afraid to do end-of-life care research. And in fact, we've seen that now with many other researchers, and it was a real learning lesson for us. So what we learned from the data was transient unassisted resumption of cardiac activity does occur, that all patients died, even if there was resumption of activity, that the cessations were about 1 to 2 minutes long, and that a 5-minute window was reasonable, even if the longest one we saw, the sensation, and I use the word transient because it always stopped, even if it restarted, was 4 minutes and 20 seconds. I think we felt good about the 5-minute hands-off period in Canada for the determination of death, aligned with what we found. But we really felt strongly that there could be a lot of error in the determination. So arterial blood pressure monitoring was really important. That scaling of the waveforms at the bedside was really important. That we didn't want to rely on ECG because that was activity, not function. And that if resumption of cardiac activity does occur, which it does 14% of the time in our study, then restart the clock and they can still be a donor because these are transient. What happened from there was timely, that in fact, Canada came back together and said, we want to redo our determination of death guidelines for both neurologic function and circulatory function, for brain death and for DCD. And in fact, our study fit timely-wise perfectly was a very comprehensive group that looked at the definitions, the ethical considerations, the legal considerations, and a lot of stakeholder involvement. Really proud of this work that, again, a lot of people on this call were a part of. And we redid our systematic review of determining how, or trying to figure out how long to wait, how to determine circulatory death. And in fact, our study then was a big part of that evidence that was used in these new definitions. So rather than just consensus, we use a very rigorous method of using evidence. And so that felt really, really great. That's not how we started this project. That's not where we were. We started with the family's needs, and we ended up in a guideline. If you're interested, I think this is groundbreaking stuff that the rest of the world is looking at on how we determine death for the purposes of organ donation. The study is carrying on in different forms. These two individuals, Murat and Tennille, are from London Health Sciences. There's another group in Vancouver that recognized as we were doing this study, that, you know, this was about the heart stopping, but in fact, as I mentioned, this was more about what was brain function doing. And so now they're doing studies looking at individuals who are in situations where there's no hope of recovering. And though we were monitoring just the heart and circulation, they are now monitoring brain function. And this may be a little bit hard to watch, but in fact, families are consenting to this. And because this is the right thing to do for families to answer the question about what is consciousness and when should we fulfill death criteria from a brain-based definition, which is really what's important. Really proud of this crew. We had these questions during our study to say, oh, should we add all these monitors? And in fact, the lesson learned was stay true to what you're trying to answer and let other people take your start and start running with it. And so that's what's happening. And I'm sure after DePPaRT, there'll be another study. And that's what's exciting about research. For the audience, in fact, the preliminary studies show that once the heart stops, that we're not seeing brain activity and function. And in fact, almost a minute plus before circulation stops, because it's a low flow state, we tend to see brain function stop. So that's, again, very reassuring. Our second objective was looking at predicting time to death, and we're continuing that study now. Andrew Seeley and our team at the Ottawa Hospital, again, looking at AIs, taking all that information from the 631 patients, and in fact, using AI algorithms to say, these are the parameters of a potential donor, especially their vital signs, their heart rate and their blood pressure, before they withdraw life-sustaining therapies, and creating prediction tools to decide who's going to die after withdrawal and at what period, and what are their organs going to look like, to create a, maybe not an app just yet, but an algorithm to support transplant teams and donation organizations to identify who's going to be the best donor. And in fact, it's not just for them. We're hoping over time we'll be able to provide this information to families, and it may help support whether they're going to consent to their loved one to be a donor. So reviewing all the study is one thing. We're in the guidelines, and that's amazing. But in fact, for this group from a CDTRP group, I think to review the lessons learned, one, the core team is so key, and to make sure that you take the time to develop that team and you're answering a question that you're motivated in and the whole team is motivated. That family partners just aren't a token, and I don't think that's the case anymore, but for us, it was just a wonderful opportunity to find that motivation. And that people are often afraid of international partnerships, but that does not have to be hard. Again, I think it propelled us. And in fact, there are ways of doing research there are different than here. We found actually there were less barriers to fulfilling our research mandate in other countries, and that inspired us to keep trying. Apart from Matt, get help from your friends. I think when I say make friends first, it's about relationships. And like Matt, it's about working through these ideas wherever you can, on the back of a napkin, to solidify your ideas and then bring people along with you so that the experience is felt. And what happens is those relationships help your own research better. And I think then build on the subsequent research after that. I think we were very lucky to be well published, but I think what we recognize is timing is everything. And getting into those guidelines was a bit of luck. And I think perfection may have slowed us down. And if we tried too much, we would have gotten stuck. And I think it's really important to keep your momentum going, and sometimes 90% is better than 100% not doing it at all. I talked about being ready for the questions that arise from your study and not having that block you, but in fact, letting other people start moving on those questions while you're finishing yours. People often ask what was the most stressful part, and it was funding. Funding was the most stressful. This takes time, and several times we ran out of funding, and we had such a good team that the biggest stress was that we couldn't pay people to do the great work. And a lot of people did the work with faith. They said they were going to stay with the team, even though there was a deadline of 3 months from now, we wouldn't have funding. And we were lucky enough to continue to keep going. And the most impactful part is right in the middle there. It's the relationships during the study with patient partners, other researchers, and clinicians. It's been super helpful. I'm going to stop there in this review of the study, and hopefully it inspires some conversation, not about the study itself, but I'm hoping about how we do research and the lessons learned. So thanks very much for me.
Thank you so much, Sonny, for once again a terrific presentation. Fantastic information. So we're open for questions now. We have about 10 or 12 minutes for questions, and I see a hand up from Donna.
Sorry, that was supposed to be applause.
Oh, sorry. Okay. Well, applause for sure. Applause all around. Do we have any questions from the audience? I don't see any in the chat at this point. So Sonny, I'm going to kick it off with one then.
Sure.
So what's the approach for aligning legislation across Canada? You know, you talked about the terminology that's usually in legislation. And how do we move that ahead? Is there any work that's going ahead through either CBS or other initiatives to do that?
Yeah, I think the first thing to acknowledge is that though we think we're a federalist and national healthcare system, it's really key to note that we're provincial. And that is one of our biggest struggles in healthcare. Maybe there's probably undoubtedly lots of benefits to that too, but for organ tissue donation, it's been our struggle in that we haven't been able to align practice, best practices at the same time. We'll get there, but we're unable to do that with one act across the country, for example. Two, it prevents us from dedicating funding that's aligned. It worked how I'm sure most of this group feels strongly about immunizations, but that's how we worked out immunization across the country for COVID, is that it was a federally funded, and there were some checks and balances with that. We don't have that for organ and tissue donation. I will say that I'm super hopeful. I think that the organ donation organizations that are provincially funded really have much stronger connections than I saw 10 years ago, that they are working together to be more aligned, that there is a great relationship from the have and the have-not provinces. And that's great to see. Two, I think Canadian Blood Services has really aligned in their mandate to do their part in creating the best practices, giving people the tools to be able to align nationally. And the third part of this is I'll add to the second part is research with CDTRP is also aligned nationally, so that's really good. And the third part is Health Canada, that they had this organ and tissue donation collaborative, which was a 3 to 4 year kind of mandate to bring everybody together. And I think they've got a new governance structure nationally that we're in the process of implementing over the next few months, that I think will start to align the provincial funding tables, the healthcare tables, to then support the ODOs and the provincial healthcare system to start aligning, so that we're going to do this nationally now. And I think there's an appetite from the grassroots and there's an appetite from the national level. And I think if we meet in the middle, I think we're going to see some positive changes. And I think it's a bit of a workaround for Canada because we don't have this federal system. But I think that I'm very hopeful. We've also got our data system that's aligning nationally. And I think that will create some accountability. And with that accountability, I'm a big fan of shame-based learning. I think it'll work. I think we'll get legislations and things start to be put in place.
Fantastic. Thanks, Sonny. Tim, you have a question?
Yeah, so a great talk as always, Sonny. I'm just wondering what can we say, or what can you say? What do we know about like what the current trajectory is of DCD, like in Canada and internationally? Like what's happening now?
Yeah, great question. I think DCD has become a standard of care. And so when we started this study, Tim, and I remember going out for dinner, and we had a lot of great people at that call. A lot of places hadn't started DCD in Canada or internationally. That's not the case now. DCD is ingrained in most jurisdictions across Canada, so we've made a huge leap, and it is the standard of practice. However, there's still reservations on time to death and recovering organs. So there's a lot, and predicting who's going to be a better a donor, so that we want to get to a point where it's more efficient, where we're finding the right donor with the right organ for the right recipient. Because right now we're probably utilizing way too many resources by trying to make everyone a DCD donor. And about 30 to 35% of potential DCD donors that consent don't actually go all the way to recovering an organ. And it's a fine balance for us. I think science can help us get to a better place where we are allocating the right person and moving forward. It's not just about money resources. It's also hard on the family when they've consented to donation, then don't get to be a donor. It's hard on the healthcare team. So I think that's our next step, is to optimize and make it a more efficient system. The other area of DCD donation that's really increasing is after medical assistance in dying. That in fact, we thought this was there was an ick factor to that, that MAID was just starting in Canada. And we didn't want to, and so was DCD. So we didn't want to bring them together. But in fact, people who are putting their names forward to having MAID are also saying, I'd like to be a donor. And so especially in Ontario and Quebec, there has been a huge advocacy from the ODOs to support that request. And I think we have to, with our criteria and guidelines on determination of death, is make sure that we're incorporating that population, because I think it will be a significant increase. And even if it's not about increasing numbers of donors, it's still the right thing to do. Great question.
Thanks, Sonny. This certainly speaks to additional support for families, especially with the time frame lag that's involved in the process and the trust factor. And if a significant number of potential DC donors don't proceed to donation, definitely providing additional resources to families through that process and that grieving process. How do you think we can best instill public trust and confidence in the process when really they just want to know, is it time or not, as they're coping with the loss of their loved one? This is all new information and process coming through. The addition of the AI decision tool. Some people are saying AI, I'm not sure if I trust it. How do we instill public trust and confidence and not lose that piece?
Yeah, great question. And then I think Murdoch's got a question. First, I'd say we need confidence in our own system. We need, the healthcare team needs to be confident. And we've had a huge culture change in, especially the ICU community across the country, that says we believe in donation, not as an afterthought to end-of-life care, but as a part of excellent end-of-life care. And that culture change was really important for us because that says trust. Trust is super important when ICU clinicians then talk to the family, nurses, RTs, physicians, talk to the families. And when they're supported in a better end-of-life situation and there's trust in end-of-life, the donation part comes part of that. And I think that's super important. I think, how do we build trust with the healthcare team? I think it's science. I think it's science and research and answering the questions that are still out there. Like, how long does it take someone to die? How sure can we be about that information? Once the healthcare professional is comfortable with that, they're going to impart that to the family. And the family is then going to be comfortable with that information and be supported in making better decisions for themselves.
So we have two more questions on the line at the moment, one from Murdoch and one from Lori. So why don't we go with Murdoch first, which is related to caregiving. Have you seen the question?
Yeah,
Sonny,
so
would you
it says,
like me to
any
read it out?
thoughts on whether donation programs should have more integrated opportunities to participate in research? For sure. Body donation we'll get to in a second. But in fact, I'm a big fan of incorporating research into the pillars of any ODO and in fact hospital. And I think we're seeing that in a lot of hospitals now and in a lot of ICUs. The Critical Care Trials Group is a big proponent. There's a lot of money invested into making research a thing when you get into a hospital, right from the beginning, no matter what that is. I think the ODOs are also getting there. And in fact, I see Ronnie on here already gave a shout out that I think Trillium took a big step by creating a systematic approach to how research is done so that researchers can go to them. Organization like CDTRP can leverage that. And I think working in partnership is super important. The same things are happening in medical schools that I'm not sure about kind of body donation anymore. And I do think that where the next step is that, like we were so afraid to talk to families and ask them to participate at the end of life, I think we're doing the same thing around donation specifically. We ask them to be a donor, but then we're still a little bit nervous about asking them to participate in other types of research relevant to donation, especially in pediatrics. And I think we need to get over that barrier. So I think it's important, as Murdoch's saying, that there's a lot of work to be done for organs and tissues.
Great, thank you. Lori, you have a question.
Sorry, unmuting. What a fabulous, I love this story, the whole story, Sonny, and it's so interesting to hear you tell it from, you know, a few years later, going back and looking at the evolution of it and when it started. And I remember when the first drafts came to CNTRP to work on this proposal. And I was personally incredibly skeptical, although I never said so, just because I thought just
Maybe
what you
you did.
described.
Maybe you did.
Maybe I did say so, but I just thought, how are they going to accomplish this? How is it feasible? And you did, and I think that speaks to the strength of the team, as you mentioned, and the way you said about it. And I just wanted to comment that brings to mind one of the things that we are trying to, that we have been trying to promote, and that your team made abundantly clear in CDTRP, is that the importance of frontline clinicians, as opposed to maybe more traditional researchers with a research background, but the critical importance of including frontline clinicians, not just physicians, but all the team members on this kind of research. It's really a tour de force. I'm so pleased to hear you speak about the necessity for embedding and integrating research into clinical care delivery, because it still remains something that's often an afterthought, and often we hear people say, oh, I'm not allowed to ask those questions or do this because it's research, when in fact sometimes it's quality control, quality assurance, but sometimes it's research, and it should be noted as such because it's critically important. And so I think we need ongoing efforts to continue to do that, because I get quite despondent sometimes that we're not that, we don't often see that much progress in a willingness to actually dedicate resources on the clinical side to research. And finally, my question, which you happened on, was the body donation, the decedent models of things like xenotransplants and so on. Do you have some thoughts on that for us?
I
Thanks,
think that's
Sonny.
an in fact, I was participated in a couple of grants last year that is looking towards that sort of research, and I think that's where we're headed, and I think Canada tends to push the envelope when it comes to these sort of advancements in transplant and research. So I think it's coming. Yeah, I think we will be looking at looking at how we manage that. I think we're also very good at not just looking at the medical portion of this and making sure that the ethical framework and the collaborative model with PFDs and the acceptance of this sort of research is gonna be key to how we move forward.
Maybe for those who aren't aware of this, I'll just briefly explain that this is where someone who had indicated a desire to be an organ donor for whatever reason could not be, but their body is then used as a recipient of a xenograft or other kinds of transplant procedures. And this has really been established in New York and in Alabama. But as of yet, I think there's one program, as you mentioned, Sonny, that's attempting to go forward in Canada.
Yeah.
So thank you, everyone. With your final question, Lori, I think we'll bring the session to a close. Again, Sonny, there's been a tremendous presentation and great questions. Thank you, everyone, for your questions and comments. On behalf of CDTRP, thank you again for your presentation, Sonny. For those with additional questions, thanks. For those with additional questions, comments, or suggestions for future topics and speakers, please contact Erica at ekcroft@cdtrp.ca. You'll also receive an email requesting your feedback for this presentation via a brief survey. Please fill it out. That feedback's important. We'd really appreciate it if you could take a few minutes to complete it. This concludes the webinar series for the summer, and it will resume again on September the 10th. So please put it into your calendar. Thank you all for your participation. Have a wonderful summer, and we'll all get over the fact that the Oilers didn't win last night.
I didn't even bring it up. I couldn't do it. I couldn't do it. I'm sorry. I had a slide and I took the celebration slide out. I'm sorry.
Take care. Have a wonderful summer, everyone. Bye now.